important is don't be a damn chicken. This industry is so afraid. I've never seen anything like it. It's like they're really afraid.
I'm Jack Whelan from Andover, Mass. I'm a survivor of a rare and curable blood cancer, a lymphoplasmacytic lymphoma called Waldenstrom's macroglobulinemia. And at the time I was diagnosed about 7 years ago, I was told that the general outlook you could expect is somewhere around a 5-year survival, which of course is not good news. And part of that was that we would borrow chemotherapies from other blood cancers. So, for example, we would try this empirical approach, try drug A, and if it failed, move on to drug B and drug C and so forth. And that, in many ways, it's like the whack-a-mole game. Sooner or later, you run out of time. So I didn't like the idea of the historical outcome. And the historical outcome we knew because of the chemotherapies that we had been using. I like the idea of forward-looking science. What's behind door number 3? What is the new stuff that's being developed in the labs, for example? And what made it exciting or interesting to me is the whole promise of the Human Genome Project, the specific development of genomic-based and genetic-based therapies, where we could look at what is the cause of the cancer, and specifically in the hematologic malignancy. What was the DNA, the sort of the software bug that caused this cancer? So I became very interested in finding the best solution for my cancer. When you're told it's rare and it's not curable, it's like being told you're going to play a game that you can't win. And that wasn't appealing to me at all. I wanted to find out, was there some other scenario? And so it was natural to me to explore what's in research, or more importantly, what's in clinical trials. And as you know, there's a lot of myths and misconceptions about clinical trials. I've since learned that when you combine the clinical trial with tumor profiling using genetic and genomic information, it may in fact be safer and more effective than conventional chemotherapy. So that's the path that I took in looking at treating my cancer.
I understand you're involved in some advocacy as well.
Yeah, I am. I think for me, advocacy was a way to learn as much as possible about this blood cancer. There are several very large professional advocacy organizations that I started to volunteer with. The Leukemia Lymphoma Society has some really good educational programs. I'm very actively involved with the American Association for Cancer Research. They have a fabulous patient advocacy program called the Scientist Survivor Program, where they team patients with physicians and PhDs and principal investigators, and you learn about reading abstracts, and you learn about what's going on, and some of the vocabulary, some of that is very important for you to understand your disease. So that part of sort of patient advocacy, to be educated, was important. The American Society of Clinical Oncology, ASCO, I'm very active with ASCO. In fact, I was on the cover of, that was the AACR Cancer Today magazine, which was all about advocacy. The interesting thing about advocacy was when I was diagnosed with a second cancer recently, a metastatic prostate cancer, which for many patients is very, very bad news. I was diagnosed late stage. I had all the bad biomarkers, a Gleason 10, a PSA of 177, pretty extensive involvement throughout the tumor samples that they took. 13 of the 13 cores were heavily involved with cancer tissue. And then my bone, it's a metastatic cancer, so it's throughout my bones. So the interesting thing, as a result of being involved in advocacy, there are a number of doctors and friends and advocates that came forward and said, hey, here's some ideas. And most important was to find the right physician, the right principal investigator to work with another doctor that I'm working with to treat this cancer. So the goal was to find the right care team and the right care plan. And that was one of the benefits of advocacy that I didn't expect. There were just so many people that came forward as a result of advocacy that said, hey, we've got to keep Jack alive. And so that was part of advocacy for me, something that I didn't expect to have happen. So.
And I understand you've written as well on the subject?
I have, yeah. pretty active speaker at life sciences conferences, and so I write a lot of documents, position papers, whether it's on biosimilars or targeted therapy. Or I'm a chronic defender of biotech and the pharmaceutical industry. These industries are constantly under attack. They're being told they're a bunch of profiteers. The current political environment is very bad for all players in biotech and pharmaceutical. I think patients can be a very effective active voice for the biotech and pharmaceutical industry. So that is part of what I'm involved with. I've testified before congressional delegations in Washington and also in the Commonwealth of Massachusetts. And sometimes that patient's voice, the patient experience, can be very helpful in legislative circles. Yeah.
So, aren't those type of papers that you described typically done by people with doctorate degrees?
They are. It's a very good point. Most abstracts that are published, that are vetted publicly, are produced in a very disciplined environment. The abstracts presented at the American Society of Hematology or American Society of Clinical Oncology or American Association for Cancer Research. These are public vetting sites where any physician or PhD or principal investigator can publish his or her work, and it's vetted by others in the industry. So it's very unusual to get a patient's perspective. I don't have a PhD. However, I'll bet I know more about my rare cancer than most hematologists know. So I think I add a unique perspective. I do caution people to be careful. I like to quote Forrest Gump, the great American philosopher, that patient advocates are like a box of chocolates. You never know what you're going to get. So it's important that if you're going to engage patients, look for patients that are truly interested and engaged and educated and have spent some time trying to learn about some key aspect of the industry. And that's what I've tried to do, is to, again, part of the education is to help me personally make the right decisions, but also in advocacy, I'm able to help so many other people along the way that may not know the information that they need to be able to survive, because it's really a very difficult situation to be in when you're told you have cancer.
You've obviously had a pretty tough road here the last several years.
I have.
How do you maintain such a good attitude?
Yeah, that's a great question. People ask, where do you get the energy? And I say I blame it on the effects of steroids, dexamethasone and prednisone. I truly do have a lot of faith in science. I think that science is working diligently. The kids who work in biotech and pharma are the ones who back in high school and college kept their head down and were always looking for the right answer. And I have a lot of confidence that the next generation of therapeutics that are just so close and right around the corner, I'm going to position myself to be there when they're ready. So I have a lot of confidence in my medical team, in the science that we're very close to. I mean, the cancer breakthroughs are pretty promising and exciting. So I expect to beat this one. Again, the numbers are pretty scary, but I will try to find the best way to do it. And I think betting on genetic and genomic profiling is one way to get there.
So I understand you were recently diagnosed with another form of cancer. Can you tell us a little bit about that?
Yeah, that's correct. I've been in treatment for this rare incurable blood cancer for about 8 years. I've been getting regular chemotherapy infusions for really the last couple of years, and I've been in treatment, as I said, for 8 years. And unfortunately, in February, I was diagnosed with another cancer. It's a metastatic prostate cancer, and sadly, it's a very late stage. I have a lot of the bad biomarkers associated with that cancer, and the sad part about it is it was the regulatory process and the government position, I think, that created this problem. And let me explain. First, I'm a disabled American veteran, so I get the benefit of an annual physical every year. And at the VA, they didn't perform what's called a routine DRE or the PSA. And the PSA is a very important diagnostic test. It's called a prostate-specific antigen test, and we're looking for PSA activity coming from the prostate gland. And so, much like the same problem we're having in women's healthcare, in men's healthcare, it's one of the most controversial issues today. Well more than 1 million men every year are overly treated for prostate. And so it's not the test that's bad, it's the treatment that we're doing. And so we need to fix the problem about treatment, not the test. So what happened is that Medicare, or the Center for Medicare and Medicaid Services, recommended that we no longer do a prostate test after the age of 65 unless you're symptomatic. So in other words, unless you're reporting, I think there's an issue. I think I'm having more frequent urinations, or I'm having bone pain, or other things like that, you won't get it. The same thing, the Veterans Administration, following the CMS guidelines, no longer do the routine PSA test. My own primary care physician, who I've been with for 20 years, stopped doing the PSA about 3 years ago because the CMS guidelines are you won't be reimbursed unless the patient says, I think I'm symptomatic. So here's an example where we need to be advocates for ourselves in our own care, but also be actively involved. When the government starts making decisions about health care, we need to be very involved to understand what those are. So sadly, I have this metastatic prostate cancer. I'm going to do everything I can to survive it. I had one particular group tell me that it probably won't survive longer than 2, maybe at best 3 years. I don't buy that. I think that we will find the right approach to coming up with a cure. So I'm glad you asked that question, because it illustrates some very fundamental problem in our healthcare system. The same issues are facing women with breast cancer, colorectal cancers, other types of cancer, that we have to be careful. We need to allow these molecular diagnostics to be done. We have to go much further than mammographies for women. We need to provide many more diagnostics for women as well. So just a little plug for men and women, especially older folks and especially veterans. So thank you. Yeah.
What did you do in the military?
I was a Navy guy. I served 4 years in the Navy, and just an ordinary enlisted guy, and no regrets.
Thank you for your service.
Great, thank you.
I was a
Good.
Navy guy as well.
Oh, you were? Oh, congratulations, sailor. Awesome. All right, good. Thank you so much. I appreciate this interview. This is good. Yeah.
So you were on a ship?
I was, yeah. So,
I was on a frigate based out of Norfolk, Virginia.
oh, you were? Okay, great. Good, yeah, awesome. Yeah. No regrets. Yeah, best 4 years. Yeah, it was a good time. Yeah. So, anyway. No, I think we've covered it. Yeah, I appreciate that this was a good interview. I enjoyed it. Thanks a lot.